Hello everyone, I'm here again to talk about using ABGs to optimize mechanical ventilation. ABGs, that is the arterial blood gas analysis, can tell you about patients' oxygenation through the arterial oxygenation and the oxygen saturations of the patient as seen in the pulse oximeter. Acid-base balance and pulmonary function can be determined through the carbon dioxide partial pressure seen in the ABGs and the metabolic status. In this video, I will focus on translating the ABGs information into clinical benefits for patients on mechanical ventilation. Endotracheal intubation and mechanical ventilation may be prescribed for patients who can't maintain adequate oxygenation or ventilation or who need airway protection. The goal of mechanical ventilation is to improve oxygenation and ventilation and to rest fatigued respiratory muscles. Mechanical ventilation is a supportive therapy because it doesn't treat the causes of the illness and associated complications. However, the ventilator support buys time for other therapeutic interventions to work and lets the body reestablish the homeostasis. When using this life-saving intervention, clinicians should take steps to avoid or minimize ventilator-induced lung injury. Patients should be weaned from ventilatory support if their condition permits. A critically ill patient's clinical status can change rapidly and dramatically, and the need for ventilatory support in terms of oxygenation or minute ventilation can vary at different stages of the illness. ABG analysis is an indispensable diagnostic tool for monitoring and evaluating the response to interventions by reviewing the patient's ABGs and clinical status. Clinicians can adjust the ventilator settings to improve oxygenation, ventilation, and acid-base balance, or wean the patient from the ventilatory support, basing on the findings of the ABGs. Normal values for ABGs vary slightly among labs, but in general they are as follows. The partial arterial oxygenation pressure, the normal range should be between 80 and 100 millimeters of mercury. The oxygen saturations normal ranges should be between 95% to 100%. The pH levels should be between 7.35 to 7.45. The carbon dioxide partial pressure should be between 35 and 45, while the bicarbonate should be between 22 and 26 milliequivalents. Serum lactate sample is often obtained along with the ABG's results, and they are normally less than 2 millimoles in critically ill patients. For mechanically ventilated patients, the key means of improving oxygenation are to increase the FiO2, that is a fractional inspired oxygen, or increase the positive end expiratory pressure, that is the PEEP. Remember that a patient's minute ventilation equals respiratory rate times tidal volume. Therefore, any intervention that alters the respiratory rate or the tidal volume can help manage hypercapnia or hypocapnia and rectify the acid-base imbalance. In volume control mode ventilation, increasing the tidal volume, the respiratory rate, or both will reduce the partial pressure of the carbon dioxide and in turn improve the ventilation. In pressure control mode ventilation, interventions to improve ventilation include increasing the inspiratory pressure, respiratory rate, or both, prolonging inspiratory time, and decreasing airway resistance by administering bronchodilators, sanctioning airway secretions, or using a larger diameter of endotracheal tube. So the dynamic approach here is because a critically ill patient's condition can change rapidly and dramatically, A dynamic reviews of ABGs are very essential. By understanding mechanical ventilation and how to use ABG results, ventilation strategies can be changed as needed to address changes in the patient's condition. I'm going to talk about steps to interpreting the ABGs. You can follow this 5 steps approach to interpreting your patient's ABGs. Is the patient hypoxemic? Look at the arterial partial pressure oxygenation as well as the oxygen saturations of the patient. Secondly, what is the acid-base balance? Check the pH levels. Third, how is the patient's pulmonary status? Look at the partial pressure of the carbon dioxide. Number 4, what is the patient's metabolic status? Review the bicarbonate levels. And number 5, do you detect any abnormalities or compensation? What's the primary cause of the acid-base imbalance? And which derangement is a result of the secondary or compensatory change? By matching the partial pressure of the carbon dioxide and the bicarbonate parameters with the pH can help you determine the primary cause and the secondary change. Also, examine the serum lactate, hemoglobin, glucose, and electrolyte results. So this wraps up the video. Be sure to subscribe, like, share, and drop a comment. Thanks for watching and see you in the next one.